I've been a rural nurse practitioner for 27 years and feel like I have subject matter expertise in rural healthcare in Georgia. I have no financial disclosures, and although I'm the director at large for UAPRN of Georgia, all of the opinions and information provided today are mine and not the organization's. Again, thank you for inviting me to participate in the conference, and I look forward. Rural Georgia is really at a crossroads. So, what I want to talk to you today about is really improving healthcare access and doing it through community-led care, whether it's physician, nurse practitioner, community health workers, doulas. I feel like for us to even make a dent in the problem, we're going to all have to participate and contribute to innovative solutions to this problem. So, the Georgia crisis, what is really going on? For one, worsening rural health disparities like Black maternal mortality. So, is this a patient access crisis, or a relative or an actual shortage of physicians? Is it a supply and demand problem? And I would say it's a little bit of all of these. We clearly have a physician shortage crisis, and I'll go into that next. Um, but we also have an access problem. Workforce deserts are present, and I'll have a slide coming up to show the number of counties where we actually have health provider service shortage areas. But the areas that are leading the way for this problem are maternal mortality, mental health, substance use disorder, pediatrics, dental care in some areas. And, you know, patients are also reporting an inability to get primary care appointments, even for weeks, with their primary care provider. And this also then becomes an access problem because um, you don't have your schedule open, you don't have same day slots, or you don't see Medicaid patients at all. Emergency departments comprise about 0.01% of all healthcare settings in this country. Yet 48% of the total volume of care delivery provided in the country occurs in the emergency department, especially in rural areas, underserved areas, and some urban underserved areas. Burnout has increased amongst physicians and nurses and all healthcare providers, physicians associates. Approximately 100,000 nurses exited the workforce after COVID in the country. So, what is the problem? Now we have a RN retention problem, a recruitment problem, a training and capacity, an issue with the distribution of our workforces, more nurses in metro versus rural areas, having to use agency nurses in rural areas. Nurses right now are not wanting to work in areas where they are not being compensated, where they feel there are unsafe patient staffing ratios, and where nurse on nurse and patient on nurse violence continues. There are some federal statutes now that are being looked at and addressed to penalize those who abuse healthcare workers. So we are making some progress. Since COVID, we've had a limited ability to predict Georgia's medical workforce and systems. Data sharing and interoperability issues linger. I mean, the problem started before, but COVID, it was extremely difficult. We do have new legislation as far as workforce. Dr. Chelsea Hagopian at Emory University has worked closely on the Workforce Board and the Georgia Board of Nursing so that we can all start sharing information and have a better ability to predict where our nurses are working, where our physicians are working, and how we can better utilize them and mobilize. Of course, Georgia failed to expand Medicaid, and this failure also contributes to an access issue because without these expansions and without also patients having Medicaid, providers accepting Medicaid, physicians and nurse practitioners, physician associates are not receiving reimbursement, and it is making it more difficult to sustain practice. And again, we just don't have enough providers at this point. We also have a lack of broadband and internet connectivity. This has also improved. It definitely improved in our county and neighboring counties. And also, we only have a temporary telemedicine extension at this time, I think through 2027. And this is something that we need to make more permanent. We found out during COVID and during the easing of um, provider barriers with the CARES Act, nurse practitioners and healthcare professionals who are able to utilize telemedicine were able to access patients remotely in their homes. And this is critical during a crisis. Black maternal mortality continues to be a problem. Black women are 3 times as likely to die or have a negative consequence of pregnancy compared to white women. And I just want to reiterate, this is not an education problem. It is one of structures and systems. It's one of access, provider bias, gender bias. We know that Black women with college degrees are more likely to die from a complication of pregnancy than an uneducated white woman. This is just unacceptable at this point. And so we've got to look at what are our professional biases, what can we do to improve access from a listening and understanding standpoint, to be there for these women. The U.S. has worse outcomes than any other developing country, a developed country in the world, ranking anywhere between 7th to 36th. I do have a little short video I'll point out down here, Voices of Impact, the Shalonda Irving story. I would encourage any of and all of you to listen to. Shalonda Irving was a young Black woman several years ago who passed away within weeks of delivery of a healthy baby. She did have some minor health problems. She was had a Master of Public Health. She was a PhD epidemiologist at the CDC. She kept presenting to the emergency department and to healthcare professionals, physicians, and letting them know that there was a problem. And she kept being told that she just needed to give it time. This is just what happens after pregnancy. So, healthcare professionals, I will say, need more education about this crisis and what we can do. Please take a look at this video. It is very moving. So, what are some of our solutions? Primary prevention through community support systems for early detection of maternal fetal complications with these preemptive capabilities. We need to continue with our critical access facilities, continue to support funding for rural hospitals and underserved communities, continue telemedicine. We need to have telemedicine support from larger facilities into these hospitals like we do at our local rural hospital. So if someone comes in with a stroke, we're able to get on immediately and communicate with a neurologist. Other innovative solutions include interprofessional partnerships. So I'm going to mention Healthy Babies, Healthy Mothers of Georgia, predominantly based in Atlanta. They do branch out. I'm going to talk a little bit about my MNES model that me and a group of colleagues from Johns Hopkins University proposed at the Emory Innovation Competition 2 years ago. But what's important is these innovations are going to require funding, coalitions, community buy-in, policy support, and membership in state organizations. So one thing that I always push is that policy should be a priority of healthcare professionals. Policy, practice is policy. Not everyone's going to get involved and be up at the Capitol, but if I can encourage you to just donate and give contributions to your selected organization of choice as PAC and get involved as much as you can. One thing that Dr. Desiree Clement found at Emory University a few years ago is that if you connect with your legislators, your representatives and senators before a problem occurs and you have an established relationship, they're more likely to be involved and help you when a problem arises. But also, it's really important to get their constituents and your patients to tell their stories. Because the thing that a story does is it leaves that emotional connection, and it's something that they will remember more than just statistics and facts. I'm going to show you a little bit. Oh, I do want to mention also the Morehouse University, Dr. Natalie Hernandez Green leads a training program for community-based doulas to help improve access to doulas. And we do know that WellStar organizations in Georgia have extended Medicaid coverage for doulas for women who are seeking care in their facilities. Peach Care has Medicaid extensions for women 12 months following delivery, which we know that 12-month period is the period where we're going to see most of the maternal complications. 80% of maternal deaths are preventable, and these deaths usually stem from things like cardiovascular events and sometimes amniotic embolism. But these are preventable events with touch points and access. So let me describe the MNEST solution. So this model was developed by myself, Dr. Kenan Thing, Anne Marie Kernan, Dr. Carrie Belin, and Dr. Melanie Morano. What we proposed was creating a maternal newborn essential team through the Department of Public Health, where you have a public health nurse as a first point of contact. You also have a mental health counselor, which could be a site mental health nurse, an LCSW, an LPC, also a doula within the community. Now, I still think one of the drawbacks in Georgia is that doulas are not consistently still being funded by Medicaid. Only certain, I believe it's waiver programs, maybe Medicaid supported programs, but we need more legislation and policies to ensure that these other essential community health workers can get reimbursed for their services, including lactation specialists. I won't go into too much detail with this slide, but this just describes the members of the proposed MNEST team. And then what I would like to show here is the timeline beginning in late gestation, or really mid-gestation, through almost a year postpartum, because a majority of the complications occur then. And we also know that eclampsia continues after delivery. Again, it's a good time for education of the patient, a good time for getting these either people into the patient's home or see them at a community-based clinic or provide a telemedicine service or consultation, possibly even with an OBGYN. So the physician shortage, relative, actual, or both. So we said it's a little bit of all. It's estimated that there are 8,000 plus shortage of physicians we'll see by 2030. And we know this is due to population growth, the aging population, retiring physicians, with almost 33.5% of physicians currently at retirement age. And we're expecting it to be 40% by 2030. Other reasons: lack of enticing social and education opportunities and activities in the community, and even possibly issues with employment for physician spouse or significant other. Professional isolation, there's the call burden, difficulty getting time off for vacation, going for CME activities. Rural physicians and healthcare professionals have very little time to get away and leave practice. There are lower financial incentives in rural versus urban areas because of reimbursement through the RUC. More uninsured in these areas too, that are creating thin profit margins for practices and for rural hospitals. The medical training pipeline continues to be a bit of a problem, although I'm going to talk about Mercer and Augusta University and their innovations and improvements that we are seeing, particularly with the rural residency and rural family medicine program. So if you look at this slide in blue, 143 of the 159 counties are health professional service shortage areas. There's estimated to be about one physician now per 2,500 patients, and about 2.7 million are living in these areas. 10 counties have no physician, and from recent research, this actually reflects an increase in this number. So, what are the implications of scope restrictions for APRNs and provider deserts? I'd like to propose that in addition, to physicians, that nurse practitioners and community workers can be a part of this shortage crisis. So part of the problem is reduced and timely patient access to healthcare services, greater ED utilization, and higher hospitalization rates. APRNs, hospitals, and clinics struggle to find collaborating physicians where we as nurse practitioners could provide care, but we legally cannot without a supervising physician in Georgia. There's an increased administrative burden between dual board requirements, between having to both be licensed at the Board of Nursing and having a collaborative agreement with the Board of Medicine. It's an increased cost for APRN practice, particularly due to lower reimbursement than physicians. So what are some solutions here? Possibly value-based care reimbursement models versus fee-for-service, which we only receive 85% of fee-for-service for physicians, and looking at things like the ACO models, which are based compensation on healthcare outcomes within your practice, how well you're able to keep your patients. Another issue is restriction of fair trade due to administrative costs for APRNs and the supervision requirement, which is not necessary in 27 states, DC, and 2 U.S. territories. Now, with the Rural Transformation Bill, this bill looks promising for opening up some funding to rural Georgia. Part of this is allowing nurse practitioners to practice at the top of their scope and training, which we call full practice authority. So if nurses are allowed, they will get a particular number of points under the Rural Transformation Bill. And with the receipt of a certain amount of points, states could qualify for $10 billion in money going completely for building the infrastructure of healthcare in rural areas, in rural Georgia. Also, one thing that is very devastating is if a nurse practitioner who is providing care in a rural area has a loss, either a death or a loss of their collaborating physician, we have a loss of our livelihood. And we understand that this is a problem for everybody that has a job. But when you are in a healthcare access shortage area and your patients need you, and your physician leaves and you have to essentially leave your patients, this can be devastating for the community. This is incredibly problematic. So let me talk about some of the provider shortage solutions. Mercer University, led by Dr. Dean Sumner from my county, has established 3-year rural physician program, moving straight into a residency. What we need with this, though, is expanding and increasing Medicare residency funding, including housing, pay for physician residents and fellows, stipends, additional benefits. What we know, though, and this is good, this is incredibly helpful data to know how to think about this, that these programs could potentially meet the needs. We are not there yet, but 56% of physicians who complete rural clinic medical residencies do practice within 5 miles of their training site, with about 60% serving in their health provider shortage areas. We need these guaranteed medical grants, not just the intermittent appropriations that get shelled out upon request right now. We also need a public workforce dashboard detailing practice location, specialty, and patient populations, ensuring transparency so that we can enable performance-based evaluations for program reinvestment. We've got to show proof in how these programs are working so that they can be reimbursed. Continue to support the telehealth policy and promote policy allowing APRNs to practice at the top of their scope and training. We have a workforce of APRNs already trained and ready to hit the ground running. Data also shows that states with full practice authority, nurse practitioners, do tend to work more in rural underserved areas than in states that do not. So we are a sustainable solution. What do nurse practitioners do? We provide primary care delivery with an emphasis on wellness and physical exams, chronic disease management with hypertension, type 2 diabetes, COPD, amongst many others. We work to ensure maternal and infant care is available, access is available. Also, psychiatric mental health care, psych mental health nurse practitioners are rapidly growing and expanding into FQHCs. This is a trend that I've seen recently. Um, we need, we collaborate with specialists. We work with home health and social services. And we're able to be in those communities so that we can observe and see individual and community needs. We're able to address and evaluate the social determinants of health, from food and housing deficits to access to timely quality care, threats from the environment, limitations in social and community-based resources, like our recent loss of Meals on Wheels. And what I'm seeing now is communities coming together through churches, through organizations and businesses, trying to make ends meet to get diapers, to get formula, to get these food delivered to the elderly who are homebound or who don't have the resources. And we know during COVID that if we had not had our schools remain open, many children would have gone without food during this time. We've got to continue to identify the structural deficits in the provision of healthcare so that we can develop policies and solutions to address the gaps in the delivery. And nurse practitioners are very good at this. We are trained in quality improvement to look for the problem and find immediate solutions. So, what can we do to modernize practice by removing these barriers? The Some of the things that American Association of Nurse Practitioners, I myself and others within the state have been doing is going to DC to work on federal legislation under the ICANN Act, which allows APRNs to write for DME, durable medical equipment, diabetic shoes, also to be able to write for um, certification of cardiac rehab. We know that when nurse practitioners are able to write, certify home health care orders, hospitalizations are reduced approximately 30%, particularly for things like pneumonia, CHF, respiratory problems. Need to allow us to certify home health care orders. We did have legislation in the House last year, did not pass because of some other things that were added to the bill that were unnecessary, and we decided not to move forward. But currently, home health care agencies in rural areas are coming to us, just as the funeral directors did when we did not have enough providers to sign death certificates to get burials completed. We need to expand Medicaid and the commercial payer recognition for Medicaid-led clinics, particularly these ACOs that I've talked about. Utilize nurse practitioners in rural health clinics and FQHCs, where nurse practitioners can be the day-to-day primary care leads with time set aside for virtual consultant blocks when we need them. Again, we're not asking with full scope to work in a vacuum. We are collaborating, but we are asking to be able to work and do what we were trained to do to help meet the needs. Behavioral integration. So nurse practitioners are able to provide brief interventions embedded in virtual care for psychiatric consults. And again, we can collaborate with psychiatrists, psychologists, psych mental health nurse practitioners for those of us in primary care who need that, and for depression and substance use disorder. Georgia still has a huge substance abuse problem with about 180,000 struggling with substance abuse. We have about 85 clinics that do provide medical assisted treatment, which is an improvement. 17%, however, is the number of patients that are actually getting medication assisted treatment. Other things we need to look at are the decriminalization of substance use and looking at these alternative discipline programs for nurses and physicians, which we just got this year for nurses through active legislation that's being enacted under the State Board of Nursing, so that nurses can, and even physicians under the Composite Board of Medicine can report substance use issues and not feel like they are going to lose their license so that they are given other alternatives to be able to eventually return to practice. We need to utilize nurse practitioner-led rural health clinics and FQHCs. What I was going to say with that is that we know that nurse practitioners are 2 times more likely in a full practice state to practice in an FQHC. We know that states that have full practice authority, nurse practitioners, patients provide high satisfaction scores, and nurse practitioner care is comparable to levels of other primary care providers, including physicians, at least in certain areas. Nurse practitioners reduce emergency department visits when they have the ability to own their own clinics and have full practice authority. And again, this is a huge problem. So many patients are seeking care in the emergency department. This is an area where I did my DNP dissertation. And if we can get Medicaid expansion so that patients have Medicaid and then allow nurse practitioners to practice at the top of their scope and practice, we will have a greater access with less need for primary care visits to occur in our emergency departments. And again, I mentioned some of the other things like reduced hospital readmissions. If you will go and look at the website below, the Georgia Budget and Policy Institute of 2027 overview, this is an organization with a board that helps review current policy, current legislation, and work as an interprofessional team to try to make suggestions to improve policy solutions. And let me go. So I want to leave you with this. I do have kind of a large list of resources here, but all of these are fairly current. Also, I have the Shalonda Irving story here that you're welcome to take a look at. Also have a couple of articles that discuss the quality of nurse practitioner care, like the one from DePriest and Doust. These are my colleagues from Johns Hopkins University. So if I could share one last thing with you, please, please, please get involved with your particular state organization, whether it's simply GNA, UAPRN, the CRNA Association, a nurse midwife association, because we need volumes and we need numbers and we need us all working together to help come together to solve the rural healthcare crisis. So this is a daycare that is near my apartment when I'm up in DC, and I just love Amanda Gorman. So I'm going to leave you with, for if there is light, for there is always light, if we are only brave enough to see it, if we are only brave enough to be it. And I would like to say, I encourage everyone just to go out there and be that light for your community. And, sometimes a healthcare provider's touch or ability to listen is all that is needed to make a huge difference. And I just want to give some information here. I am always available and welcome to discuss and even help you maybe get to an area of interest if you're interested in joining and getting more involved in these efforts to help improve practice in Georgia. So my email address is here. This is the UAPRN website. Anyone that is a student or nurse practitioner is welcome to join. So again, I'd like to thank you for having me here today just to share a few insights, and enjoy the rest of your conference.